Hi everyone, this is Dr. Isabelle Amigues, your friendly rheumatologist. Today we're talking about Behcet. Okay, Behcet is a pretty rare in the US, but still common condition that is an inflammatory condition and is actually can involve the vessel, can involve pretty much almost every single organ. And it's something that we see more in the Mediterranean, the Silk Road. So it goes from the Mediterranean all the way to Asia. But because in the US we have a lot of immigrants and a lot of people who are, from different backgrounds, it can definitely happen. So I'm Dr. Isabelle Amigues, a rheumatologist that both trained in France as well as in the US. I've done 2 trainings in rheumatology. And because I have been in Paris, I've actually seen quite a bit of Behcet syndrome. And it's because sometimes we wonder about Behcet, and you will see why. I wanted to discuss this with you. I apologize for the way I'm looking. Apparently, there's a filter that I don't know how to remove. So I'm really sorry. I look very smooth right now. I'm not that smooth normally. So I'm so sorry. It is what it is. And I would rather you focus on what I'm teaching you than on how I look. First of all, for those of you who are watching this live, please put a hashtag live. If you're watching this as a replay, please put a hashtag replay. And yeah, we're gonna talk about Behcet. So Behcet is a very interesting condition that is actually associated with some sort of genetic component. It's very often we can have the HLA-B51 positive, but the truth is that you don't have to have this, and also you can have that HLA-B51 and not have Behcet. As usual, a test doesn't make a diagnosis, but really the idea is how do you present? What symptoms do you have? Okay. Like a lot of rheumatologic inflammatory conditions, Behcet can be very mild or very severe. And the role of your doctor is going to be to diagnose what it is and also to look and prevent further complications. Okay. So, in general, what we consider like Behcet disease is what we would call a vasculitis. So, it is an inflammatory condition that affects multiple organs. The almost like the one thing that almost every single patient have when they have Behcet is ulcers and recurrent ulcers of their mouth, what we would call in layman's term canker sores, as well as in the genital area, right? So you can be someone who has a lot of canker sores, not a problem if that's all. But if you do have genital sores on a regular basis and also oral sores, and that you have some sort of Asian, Mediterranean, North Africa descent, I would recommend you get evaluated for Behcet's disease. The other thing that happened is that it doesn't necessarily it's not like you slowly have this and it stays there. It is an inflammatory condition that has peaks and flares and then come back down and then flares again and so on. And again, the role of the rheumatologist is going to be to try to decrease the amount of flare, to actually stop any amount of flares with the least amount of medication. Okay. Because it is immune, sorry, immune mediated, the role of our treatment is to decrease this inflammation. And so often it uses immunosuppression. All right. So, sorry. How does it present, right? Well, it's not a single organ. It is a pattern, right? I started talking to you about the ulcers of your mouth, of your of the mouth, of the genitals, and then there are other symptoms that I think are important. And like, what do we think about? Like, how when as a rheumatologist, what am I thinking about when I'm seeing someone with what symptoms are going to make me think of Behcet? The symptoms that are making me think of Behcet is one, is this someone that potentially is from this Silk Road? So North Africa, Mediterranean, Turkish. Turkish is very prevalent. Behcet is very prevalent in Turkey. And then, the Silk Road all the way to Asia, right? Then the second is usually young adults are being affected, 20 to 40 years old. And when we talk to them, they usually have recurrent mouth ulcers, recurrent genital ulcers, and then we can see some skin like acne that they never had before. It looks like acne. It's news, like it's a nude form, and it looks like acne, or some sort of pustular lesion, which we call pseudofolliculitis, because it looks as if it's surrounded like around a hair follicle, but actually it's next, and it has nothing to do with the hair follicle. But it would look like it if you just go and look at it very fast. And then you can it's someone who has or who is or has had some sort of eye inflammation, where there is blurriness, loss of vision, pain when we're looking at the sun. Okay, uveitis is pretty that's what we see. So an inflammation of the eye, and it's not necessarily red, although it can. Some of the other lesions are like or other involvement of joint pain that's usually inflammatory. So joint pain that's worse in the morning, associated with morning stiffness and swelling or swelling. And then the other involvement that can actually be pretty severe are neurological issues. So confusion, anger, like just not being ourselves, or someone that just presents different headaches, maybe seizures that's also possible, and then foot drop, sensation that something is going off in the hands, like some pain that can happen. And then finally, and those can be quite dangerous. And then finally, the involvement of vessel, because it's a vasculitis, so it's an inflammation of the vessel, and it can cause deep venous thrombosis, superficial thrombosis, so pain, but it can also cause aneurysm. And sometimes patients are going to present with coughing up blood because it breaks inside the lungs. And so we have blood then as you cough, right? So as you can see, right, it can be very mild with just oral ulcers, genital ulcers, that's it. Or it can be very severe with involvement of the nerve, the brain, vasculitis, like severe vasculitis. And that's the problem, right? Like pulmonary aneurysm can be deadly. And so our job is going to make the diagnosis when it's really minimal, so that the severe forms don't ever occur. Okay, so that's really the role of a rheumatologist there, right? And so the clue of the diagnosis is one, thinking about it. So when I was in Paris, it was much more common to think about it because there is a very strong North African population, either direct immigrant or descent of, that is actually what makes Paris so fun, because there's a lot of melting pot. And we were thinking of Behcet a lot more than I would here in Colorado, for example, right? But it does happen, and we have to know, right, how it looks. And then, we really the role of the rheumatologist is going to be to ask our patients like what symptoms they have, to really check what previous symptoms they have. There is then one other symptom that I find particularly interesting and that can really help in figuring this out. It's called the Pater-G test, but you don't have to do a test necessarily. You're going to see it can be just a manifestation, a clinical manifestation. And so the Pater-G test is when you're taking a needle and you're poking the skin, and you actually see a reaction to that poking the skin, which normally you wouldn't see that. And so someone who has had a blood test and suddenly gets a real reaction, redness and bump at that site, we have to think that that's a Pater-G test. And that's one of the only reason to have this Pater-G test. It's Behcet. So something to think about if you ever been poked in the vessel particularly, and you have had some reaction, and you have some origin in the Silk Road of descent, think about that. Okay, so that's some of the things that we're thinking. And again, we're asking oral lesion, genital lesion, eye involvement of inflammation, any skin rashes, any skin pustule, that, erythema nodosum. So that's like, it looks like it's painful. It's usually on the shins, and it's painful hematoma that are well circumscribed. It's like, well, I didn't bump my leg here. Why do I have this erythema nodosum? And that's not, it happens. It can happen in other rheumatologic disorder, but I would say, like, do and see a rheumatologist if you have those, okay? And joint involvement, we're going to look at that. Vascular involvement, is there any sort of rash? Is there any sort of GI issue, blood in the stool? Those are like important. And usually when it affects neurological issues, when it affects the nerve, we usually see it, and our patients like really, they usually go to the ER, honestly, when they have that. So it's not as hard to diagnose then, right? So it's not one single symptom that's going to diagnose you with Behcet, but it's really like a constellation of different symptoms all together. And it's also like, you have had this in the past, right? There are other symptoms such as fatigue, fevers, weight loss that we have to think about, but I would say those are non-specific. They can happen with many other rheumatologic disorders. They can happen with infection. They can happen with cancer. And so that's the job of the physician to figure out, is this rheumatologic? Is this is this infectious? Is this cancer, right? So that, something that we want to see. So in terms of testing, when you're thinking, okay, do I have Behcet? I would say, one, if you have a family history of Behcet, even if it's far away, because that means that you have the probably genetic background. So we want to, look at that. Then the second is that if you have a family member, we do think that you're more at risk to develop it, that your parents had it. And then it can be a little bit more severe and also can come a little bit earlier. So don't wait, right? When we have treatment, we can treat this. Other than that, it's really, I think that the most important for me, like the one that I always think about, is, do you have recurrent oral and genital ulcers, right? Like that's a pretty easy one. Think about that. And if you have this, then I really do think in this case, you want to be evaluated by a rheumatologist, because it's the clinical exam that's going to be the most important. In terms of testing, we can see inflammation, but honestly, we don't have to see it. So we're going to say, we're going to check blood count. We're going to check if you have any like sort of renal issue, electrolyte issue, liver function issues, right? So a comprehensive metabolic panel. And then we're going to check the ESR and the CRP, which are inflammatory markers. But sometimes those do not pick up the inflammation that you actually have, because you have to have quite a bit of inflammation to see this elevated, okay? So that's not enough. And then, I think that it's worth it to check your HLA-B51, just because once you have it done, like once you've done that test, you don't have to repeat it. It's either positive or negative. It's not going to change. It's how you're made, right? And that doesn't necessarily mean you have this. It's just good for us to know, okay? It's not, again, and I think I say this over and over again in those lives, a test doesn't make a diagnosis. So your test can be negative and you may have Behcet disease, and the HLA-B51 can be positive and you don't have Behcet's disease, right? And so then that's the question, is why did you check this in the first place, right? Did you check it just because you wanted to check it? Or did you check it because you have some symptoms? And then your rheumatologist is here to figure out what's going on, okay? Of course, we would send you to an ophthalmologist just to make sure that you haven't had an inflammation. It's not an optometrist, it's actually an ophthalmologist. They need to look inside your eye to see if there is any inflammation, any vessel issue, and so on. If you have any sort of issues from neurological issues, we will do more testing. We might do ultrasound. We might do MRI, depending on your presentation. And we always check urine for protein or blood in the urine, because it can affect the kidneys, although usually that effect is not really severe. So that's not the main complication, okay? All right. Once we have a diagnosis, how do we treat? As always in rheumatology, the treatment depends on how severe your presentation is. And so we could actually be very moderate, just use colchicine, which is a treatment that we use in gout that can really prevent inflammation, can really prevent flares. And so we use that when you have oral ulcers, genital ulcers, as well as joint pain. We can also use some biologics like apremilast that does help, and it's FDA approved for oral and genital ulcers. It can also help with joint pain and some skin involvement as well. And then, if you have very severe involvement, then we use much harder drugs to really decrease the inflammation. So, of course, we use steroids, and then we use some other medication that are going to immunosuppress the system. But again, those are rare cases, and it really depends on how you present. So really, that's what it is. I think, to kind of like put it all together, it's not common. All right. Not in the US. I would say it's not common in the US unless you are part of a community that is, a descent from the Silk Road, which I find really cool, actually. Like thinking that the genetics corresponds to the Silk Road, I think that is very, very cool. And so that's the first thing. And then the second is, if you have genital or oral ulcers, think of it. And then if you have some sort of new acne, follicular rash, or that you have or pustule rash, that's what I meant, and that you have like some sort of fevers, new rashes, joint pain that's worse in the morning, associated morning stiffness, and you're between 20 and 40 years old, then I think that that's when you want to think about it. Okay. We have treatment, so you don't have to despair. That we are not in 1990s, which, at the time we could still, treat, but now we have so many more options. Okay. And I think that that's about it. And of course, as always, if you are in Colorado, in Denver, or in Boulder, or the area, and you're looking for a rheumatologist, we are still at Unabridged MD accepting new patients, and it will be my pleasure to take care of you. So just all at us at info@unabridgedmd.com, and it will be a pleasure to see you. Until next week, I wish you a really wonderful week. I'm going to just say hi, Clea. It's always a pleasure to see you. And then good self, and then hold on again. It's always a pleasure to see everyone. And if you're watching this on replay, hi in advance. Take good care. I'll see you next week. Bye-bye.